Bismillah ar-Rahman ar-Rahim. First, I would thank Professor Ayman Fakhri for his kind introduction, and I hope we all have a nice time and a tremendous meeting about the Venous aspects, all Venous aspects in our conference in the Egyptian Venous Forum. My talk will be about the clinical assessment of varicose veins. And before I start with, we have concerning varicose veins, we have to build up our expectations that the varicose veins is the problem that facing our patients, but when we are doing clinical assessment of varicose veins, we have to pay attention that we are not going to treat the disease or not to treat the duplex finding. We have to treat the patient. And so the discussing with the patients all aspects of the problem and and her or his expectation about the outcome is very and crucially important. Sometimes when you examine the patient, you expect to have, or you may find that your plan of management is going in certain direction, but the patient on the other hand say, no, this is not my goal. I'm really thinking about another thing which is totally different from your point of view. So when we are doing clinical assessment of varicose veins, we have to keep in mind these expectations and to go through with this important aspect. First, before doing clinical assessment of varicose veins, or before taking or doing history and physical examination, we have to care about the presenting symptoms. We should care about it. These presenting symptoms, what the patient needs to treat, what the patient what is bothering the patient. And so we have to go to the second step, that what is the pathophysiology of his problem? Is it a problem of reflux, a problem of obstruction, or what is the problem? What is the problem he's facing? Okay, this should be kept in mind on taking history and then doing examination. Should be in the background. The third step is the diagnostic studies. What are we going to do for this patient? Are we going to do a duplex? Some patients may need further cross-sectional imaging. It depends. So we have to build up our data. So after having a diagnosis and localization of the disease process, we keep in mind, we should pay attention for the presence of risk factors for any intervention we are going to do. The functional status of the patient, is a disabled patient, or he can going his daily activities without any problem. We have to keep in mind also the natural history of the disease. Sometimes the patient comes with varicose veins. He says this is the problem for many years ago. So you do not expect that it will become more and more prominent for the few months or even in the few years thereafter. So we have to pay attention to the natural history of this problem. And then after we do or build up our risk stratification, we build up the whole data about our patient, and then go to the treatment. The treatment start with the risk factor modification. We have to change the lifestyle of the patient. We should not go immediately for intervention without changing his lifestyle. And then to keep in mind the pharmacotherapy using venoactive drugs, and lastly the intervention. You should keep this anatomical consideration. You should keep it in mind. We have to know, sorry. Okay. We have to know the certain anatomical concentration. We have to talk, all of us, we have to talk a common language, that This is the normal anatomy we all know, but we should take care about the from the start about the pudendal veins. This one of the exit points from the pelvis, together with the obturator site or the inguinal point, beside the sciatic and the greater the less the gluteal point, sciatic point, which are the exit point from the pelvis beside the clitoral point. So we have different aspects of exit point from the pelvis we should keep in mind when doing our plan. Besides, it's this is the anterior accessory saphenous vein. Sometimes we face it very much in our practice. It's a source of recurrence, so we should take care about this vein. Sometimes after, if you miss it, we immediately or within short time we may have a recurrence of the varicose veins. This is it's a great saphenous vein. This is we all mention, we all say it's a great saphenous vein. No more saying long saphenous or short saphenous. It's a great saphenous vein, and the perforators surroundings. We have the thigh perforators and the leg perforators. Also, we should know always, as I mentioned, we are talking at the same language. So here we have the deep system. We have the femoral vein. So the femoral vein is not more saying superficial femoral vein. It's femoral vein. We have femoral vein and the profunda vein, or the deep femoral vein, and the common femoral vein. Okay. Also have to keep in mind the saphenous nerve. As we are all saying, the saphenous nerve came in nearly in the lower part of the distal part in the leg. The saphenous nerve is greatly intimate to the saphenous nerve is greatly intimate to the great saphenous vein. So when doing an ablation, we don't do any thermal ablation at this area so that not to injure the saphenous nerve. So looking on the back of the leg, of the back of the thigh, we have the intersaphenous communications, the Comini vein, and the same for the short saphenous. For the small saphenous vein, I mean, we have to take care about the chural nerve, which is an intimate relation to the small saphenous vein, and should be kept in mind during doing any types of ablation. Clinical evaluation, when are talking about clinical evaluation of the varicose veins, typically you have a certain presenting symptoms. These symptoms include the pain, weakness, and sensory complaint. That's hypersensitivity, numbness. The patient is always saying that he's sometimes abnormal sensation related to his limb. Also, the pain. This may vary from very just disabling or dull aching pain in his limb to a clear or evident venous claudication. So the pain, the disabling, the dull aching pain, we commonly face it with varicose veins. But when it comes with the venous claudication, which is another type of effort pain, we face it with problems with the deep system. Also, sometimes the patients say, yes, I'm having heaviness in my limbs, have night cramps, especially at the end of the day. But to take care that when the patient is talking about this point, we have to keep in mind the pelvic source of varicosities, because sometimes this pelvic heaviness or the pelvic pain is sometimes manifested with heaviness not just in the limb but in the lower abdomen. Also, we may face some discoloration or hyperpigmentation. and the presence of swelling, edema, and the swelling and edema and the varicose veins is just a just a positional edema related to the foot. But when it comes a little bit higher, involving the leg or the thigh, we have to think about a different issue. That means that may be a problem which related to the deep system. So take care with the sequelae of the deep vein thrombosis or any other or lymphedema when you have a diffuse limb swelling. We also may face the tissue loss or ulcerations and presence of any red or tender areas indicating superficial thrombophlebitis, or simply the patient may come with bleeding, which is really just a trivial trauma, or even without a specific or recognized trauma to the limb, the patient comes and say, I'm bleeding. And lastly, this, of course, the varicosis itself, its sites distribution, whether it's in anatomical sites or it's haphazard arranged, or an abnormal site, back of the thigh, posteromedial, which is can pick up or can indicate presence of pelvic varicosis as well. And last, we have to keep in mind the malformation, the venous malformation. Sometimes the patient comes with venous malformation, the limb, and should be not to be confused with the typical varicose veins. The history should identify and characterize the location of symptoms, whether unilateral, bilateral, proximal, or distal. Also its onset, course, and duration, whether it's become more and more worse or unchanged, whether it's continuous, intermittent, and the sequence or the sequelae of the problem. If it come from top downwards or bottom upwards. This point is very important because sometimes we have patients that have a pelvic pain or pelvic problems and the same times have lower limb pain. To which of which we have to start with, which of which we have to treat first. And we have to consider or to talk with the patient if it's a problem of your abdomen first or your limb first, and then we treat accordingly. Also have to consider factors that increases the symptoms, including position, activity, here the cycles with, and the coitus, especially with pelvic problems, besides the pressure. The physical examination, we have to consider the position and the exposure of the patient. The patient's always or mostly is standing, exposing his abdomen downwards and post lower limbs, covering the genital or the external genitalia, and the patient is standing and going around to get all aspects or to get different areas of the varicose veins. We have to consider these varicose veins with how they are distributed in his limb, on her limb, its extent, pattern is taking telangiectasias, reticular veins, or more than this. We have to take about the pattern and the shape of the varicoses. We have to seek for the evidence of skin change, including pigmentation, cyanotic patches or bruises, presence of sclerosis. Also, we have to take care from her or his edema, and to differentiate or to compare between both sides. Tissue loss and ulceration, we have to locate the size, the depth, and presence of associated cellulitis, which is commonly seen with patients with lower limb problems, that the patient is coming with just some varicoses and associated cellulitis, and the problem is just here is not his varicoses at all, but the recurrent cellulitis the patient is having. You should know that every pain in the limb, we have to exclude any arterial component. Before doing our venous interventions, we have to even conservative measures when doing compression, we have to exclude any ischemic problems because it may change our practice or change our plan when doing when treating his varicoses. we have to, when the patient is coming, for example, with a venous ulcer and associated lower limb problem, lower limb ischemia, I mean, we may consider treating the arterial aspect before furtherly going with his venous problem. We have to exclude other causes of pain. Sometimes the patient is coming with some scattered varicoses, but the main problem is not her veins at all. The patient may, especially in a morbidly obese patient, she may suffer from osteoarthritis. Patient may have sciatica, or patient, the diabetic patient with peripheral neuropathy, sometimes relate their pain to the varicose veins. Also, we have to know that there is some venous scores. We have to keep it very importantly know that these scores is a very useful tools to build up your management plan and to detect the severity of your patient, and that we can categorize the severity, whether it's just a very mild problem or it's a severe problems that we have to deal it with very cautiously. We have different scoring system like clinical, etiological, anatomic, pathological, pathophysiological SIP classification, the venous clinical severity score, the venous segmental disease score, and the venous disability score, beside the Villalta score we choose for PTS. This is the famous SIP classification, the different aspects, the clinical, starting from just small veins to varicoses, to edema and skin change. The etiology, whether it's primary or secondary, if it's superficial anatomy, superficial or deep, and the pathophysiology is it a fracture or obstruction. The venous clinical severity score it's not a static classification score like the SIP classification. The SIP classification a little bit is a static classification, but the venous severity score is a dynamic one. It can classify the problem from just mild problem, moderate or severe, from different aspects of venous symptoms, from pain, varicoses, edema, pigmentation, ulceration, and even with using compression therapy, if the patient is using it intermittently or fully complying with his compression stocking. The Villalta score is a very important score which is used for post-thrombotic syndrome. It consists of 5 symptoms and 6 signs, addressing different aspects of venous problems facing patient with post DVT, after deep vein thrombosis. However, it has been criticized that it is of low specificity and sensitivity, and it does not address the problem of venous claudication very well. So it become combined with the quality of life to get a better scoring system for the post-thrombotic problem. The duplex. After we have done our assessment, we have taken the proper history from the patient, doing a proper clinical assessment, we should go for the duplex. What I want to say that the duplex is your tool, is the vascular or the venous surgeon or the venous interventionist tool, that the duplex may needs a lot of details. That's may not in our scope, but at least every surgeon, every vascular surgeon should know, or I think he should do his own duplex by himself to get the very important points he needs to know. He should the deep system, the superficial system, and to know different aspects. Just to know about the deep system, whether it's patent or refluxing, there is no obstruction. The superficial system, what about the great saphenous, the small saphenous, and the intersaphenous communications, truncal veins. the junctions, the perforators, and the the perforators, and to not every single perforator we have to go through or to seek for it. We have to define what is the pathological perforator, and it is now defined that the pathological perforator is that perforator which is related to an ulcer or within an ulcer of diameter more than 3.5 millimeter and reflux more than 500 milliseconds, that say more than 0.5 seconds. I got the duplex machine here with me just to assure this point that the duplex is very useful tool. We have to all use it, and I would like to just I have a volunteer patient. I want just to how to introduce how to confirm or to complete our assessment for patient with varicose veins by doing the duplex. For our younger colleagues, the word the duplex or the word Doppler. The Doppler is the scientist who was in the born in 1803. And he describes the Doppler effect. The Doppler effect is a change in the wavelength and whether it is crowded or spaced, and this changing wavelength is indicating that the object is moving towards the source or away from the source, and we use the same this duplex effect in the submarines and I mean when when you're using the submarines so that not to collide or to hit any object underseas. The duplex. Just as for very minimal descriptions, that the duplex have different modes. We have the B mode and the color mode and the spectral wave or the pulsed wave pattern, and beside the power Doppler. The first, the B mode, which is the brightness mode, which is just white and black. It's used just to delineate the anatomy. Just to delineate the anatomy and to know what is you are dealing with, what you are dealing with, the diameter of the vein, the size of the vein, is it compressible or not? Is it thickened or thin? This point is taken by the P mode. The color Doppler, when we are dealing with the color Doppler, here we want to say to see the direction of flow, whether it is coming towards or coming or going away from your probe, so that to detect the presence of reflux. And lastly, the pulsed wave Doppler, we use it to detect velocities, to see the peak systolic velocities and systolic velocities. Sorry. when we are using the our machine or the probe, we have to know that this probe you have to use it with the proper handling. That as you see on the screen, the left aspect of the probe, or the aspect which is nearer to the thumb, should be at the same aspect here on the screen, and not like this. The left aspect will be on the right aspect on the screen, but it should be in the same line. This is very important to avoid any disturbances during doing the assessment of your varicose veins. So you can what? ممكن تفتح. We can defer this aspect just for technical problem, and we can proceed for the next week. Talk of this, or we can open for discussion for this session until we just fix this problem. To wrap up my talk, as I mentioned, that assessment of varicose veins is greatly, you should know the patient expectations. We should know where are we. The patient should know that this is a problem which is a very long-standing problem. Yes, we try to change the problem for a certain point, but we have that the patient know the ceiling of this problem, and to know your expectation about dealing with this problem. Thank you.